Hi everyone, and welcome to the sixth and final lesson on malaria and mosquitoes. The focus of today's lesson is going to be on the treatment of malaria. Okay, so we'll get started. Now, in this lesson, you're going to learn the different methods of anti-malarial therapy and how malaria can be prevented. To be successful, you're going to watch this pre-recorded video till the end, take notes, and correctly solve question 8 of section 4 in the worksheet booklet. And as per all the other lessons, if you could please provide feedback on Verso using the code that's up on the website, that would be great. All right, so we've only got 2 statements for today. This lesson is not as long as some of the other ones. You'll have to explain the different types of treatments for malaria. So take a minute to decide, do you agree or disagree with this in the beginning? And then we'll see how your understanding has developed towards the end of the lesson. And I can explain the preventative method or methods that can be used in regions with a high malarial incidence. So just take a minute, decide on whether you agree or disagree with those in the first instance, and then we'll get started with the lesson. All right, so with anti-malarial therapy, it's important that you understand that there are a range of things that we can target when we're trying to treat or prevent malaria. Now, the very first anti-malarial therapy that I'm going to talk to you about is something called prophylaxis. And when we talk about prophylaxis, we're generally talking about a preventative measure. So it's usually something that's given to people even before we assume they've contracted malaria. So for example, if you're traveling to an area that is known to have a high malarial incidence, it's likely that the doctors will prescribe a prophylactic for you. So we look at something like, and I'll just move this up a little bit so that we can look at this more clearly. So if we're looking at the prophylaxis, there's something called casual prophylaxis and there's something called suppressive prophylaxis. And we'll start with casual prophylaxis. And by the way, if you wanted to take notes on a similar flow chart, I have added a blank template of this flow chart for you. It is in PDF format at the moment on the site, but you can make something similar to this using something like Lucidchart. Otherwise, you can actually draw this up or just convert the one that I've made into a Word document. Right, so we look at something like casual prophylaxis. Now, what this casual prophylaxis does is it targets the pre-erythrocytic phase. So we're actually looking at the hepatocytes. That's what it's actually working on. So it will kill sporozoites before they can even enter the liver cells and cause any problems there. So before they even develop into merozoites. Now, the type of drug that is used for that is something called primaquine, and it depends. Sometimes it depends on the commercial name that they give to it. So sometimes it's without an E, sometimes it is with an E. So it just depends on what name the industry's actually given it. Now so that one's our casual prophylaxis. Now there's also suppressive prophylaxis, and in suppressive prophylaxis, what happens there is this one actually targets the schizons of the erythrocytic phase. So at this point, what's happened is the life cycle has already started. It's already started some of those problems in the liver cells, but what it's actually going to prevent now for something like a suppressive prophylactic is it's going to, whenever the schizons are formed in the red blood cells, it's actually going to target those and prevent that from bursting and allowing more of those merozoites to enter the red blood cells. So the type of antimalarial therapy given there is something called chloroquine, or you can also use doxycycline, which is an antibiotic. So primaquine and chloroquine are antimalarial drugs. Doxycycline is actually an antibiotic, so it's more of a broad spectrum antibiotic. So those are your 2 prophylaxis antimalarial drugs that we're going to talk about now. And those were the ones that if somebody still hasn't actually acquired the disease. Now we move on to the next one, and that one is the therapeutic antimalarial therapy. And this, of course, this is basically used if we assume somebody's already got malaria. Now, this one actually is a clinical cure, and it targets merozoites in the erythrocytic phase. And what it's actually trying to do is it will try to eliminate them. Now, if you want something really strong, so if we believe that this person's at risk and that they are getting really sick, then they're given something like chloroquine or quinine. If, however, it's something that's low efficacy, we don't want it to be too potent, then we'll give them something like tetracycline or clindamycin. Now, don't forget that when we're looking at the low efficacy ones, we're looking at general antibiotics, but when we're looking at the high efficacy ones, we are looking at potent antimalarials. And of course, because antimalarials have really strong side effects, sometimes they'll prefer not to give those unless, of course, the disease is getting out of control. Now, the next one is the gametocidal. And given by its name, it obviously means to kill the gametes. And what it will do is it will target the gametes from the blood of the host. So remember we said in the red blood cell, when we were looking at the erythrocytic phase, we said that the gametes would be formed inside the red blood cell. Well, something like primaquine is actually able to kill most species gametes, even when they're at the mature stage. So primaquine, as you can see, can be given as a prophylactic, or it can also be given as a gametocidal. So another thing that we can basically give other than the primaquine is something called artemisinin. And those are given at early stage gametes, but they won't work on the more mature ones, whereas primaquine will. Now, if we're looking for a radical solution, so something to completely eradicate the parasite from the blood, then primaquine, again, is also a very good type of antimalarial drug. And you've also got things like tafenoquine as well that can help in eradicating the parasite. So generally, the idea is just that you understand that when we look at antimalarial therapy, we either use it for preventative, or there's a therapeutic once somebody has the disease, or we're eliminating the gametes, or we just want to completely eradicate all of the parasite from the blood. All right, so we'll move on. Now, when we look at preventing malaria, we generally want to think of anything that will kind of prevent if basically the mosquito is going to bite you. So what we're looking at there is we're looking at full body clothing, sleeping in insecticide covered mosquito nets. So, you've got those mosquito nets. For babies, sometimes what they've actually got is they'll have a crib, and it actually has a mosquito net with a zipper around it. So they'll actually encase the baby in that. You can also use indoor insecticide sprays, and we've all used those, I assume. Something that's really important is getting rid of stagnant water collection. So if you've got ponds or anything like that, it's a good idea to get rid of those. All right, now malaria can come back and it can strike again. Now, something that you need to understand is similar to when we have bacterial infections. If we don't treat malaria well from the get-go, then of course we're going to end up with something called recrudescence. And basically that means that we didn't eliminate all of the infection. And so as a result, we've developed more highly resistant strains. And so of course that you can get malaria recurring in the patient. Now, sometimes there'll be a relapse. And remember, when we looked at the different strains of Plasmodium, we said that you've got some that form merozoites straight away, and you've got some that form hypnozoites. Now, the problem there is, if you were to form hypnozoites and they stay in the liver, and you may have been infected by two different species. Now, you may have eradicated the first one, but what happens then is you've still got the hypnozoites in the liver. And so what happens is then you can get the infection developing again. So it's really important that you understand that there can be a relapse if you have hypnozoites remaining in the liver. And of course, reinfection is basically you're in an area that has high prevalence of malaria. And what happens there is that you basically end up with, and I'll just move this in case you're taking notes, and you basically end up with an infection that occurs due to another strain or another plasmodial species. So it is quite common that things like that will happen in endemic areas where they've got malaria and it's quite persistent. Okay. So we'll move on. All right, so they have tried to come up with vaccines in the past, but there is a problem with producing a vaccine for malaria. Now, the most common problem that they found is that plasmodia will mutate, and because it's constantly mutating, there's a large variety of antigens. Remember, whenever we're making a vaccine, what we're doing is when we were looking at the RDT, the test that is going to diagnose malaria, remember we spoke about antibodies. Now, a certain antibody will lock in with a certain antigen. And the problem here is if the antigens are constantly changing because this species of Plasmodium is constantly mutating, then it's really difficult to put an antibody that's going to cover all of the antigens in a vaccine. And so as a result, what happens there is you kind of have to keep up with all of the new strains, and it's difficult because it's costly to make these vaccines and to run the clinical trials. And as a result, it's really difficult for them to keep on producing more and more of those vaccines. So that's one of the biggest problems. Just remember, the Plasmodium continues to mutate. When it mutates, it's forming a new variation of itself. A new variation of itself will have different antigens. And because it has different antigens, it means that the antibodies that we're used to treating one antigen with will not work on the other. So that's the problem with the vaccines. However, there is a new vaccine called the RTSS, and some of you might ask, what does RTSS stand for? It actually stands for a series of codes for proteins within the Plasmodium. So we're not going to go through those because it's above the level that you are required to know at this stage. But this RTSS vaccine was actually produced by GlaxoSmithKline, which is a pharmaceutical company, and it works against Plasmodium falciparum. Now, what this one does is it actually contains parts of the coat of the sporozoites. And so because it only contains parts of the coat, it's not going to infect the human. So what happens is they introduce that into the body. Now, your body can see that this part of a coat has come in and there's an antigen there. There's a coat basically that says, well, I've now entered the body and here's my antigen, and it's saying I'm a parasite. And so what happens there is it basically is going to initiate an immune response. So your white blood cells are going to go, hold on a second, we've just got this intruder coming into the body. So they're going to create antibodies. Now, what that does is it kind of creates an immune response, and that is going to create memory within your immune system, so that the next time you're affected by a sporozoite of the same kind, then, and we're talking about Plasmodium falciparum in this stage, then the assumption is at the moment, based on the clinical trials, that the body will have formed that immune memory, and as a result, it will be able to target any new Plasmodium species that come in of the kind Plasmodium falciparum. So that's one vaccine that claims to be working at the moment. Now, there is a video that is up about this vaccine. To be honest, I watched the video. It does show you how the merozoites enter the red blood cells. It doesn't say much, but if you go into this article, and you can find this and click on the link using the slides, because the slides are up on the website. There is an article about it if you just wanted to read some more. It's not necessary, but if you find you just want to do some more reading on the vaccine, then that's available for you. I'd like you to please solve question 8, and it says, it has taken over 20 years to develop a vaccine for malaria. Suggest why it has taken this long to develop the vaccine. I have mentioned that in the video, so if you weren't paying attention, you might want to go back and watch the video again. And how is the new vaccine RTSS believed to prevent malaria? I've also gone through that in the video, so hopefully that'll help you answer the questions. So, one last question I have for you is, why is malaria still present then? If we found all of these therapies and, we are eradicating a lot of it, we understand that there is a mutation, but there's a bigger problem beyond the mutations, and it's actually something called sickle cell anemia. Now, red blood cells that don't have enough hemoglobin in them sometimes will go into a sickle shape, and that's the shape right here. So it's kind of like a crescent shape. Now, some people are born with a disorder called sickle cell anemia. And with sickle cell anemia, like I said, because it forms that crescent shape, what happens is when the merozoite enters the red blood cell, it can quickly cause it, because remember, it's using up that hemoglobin, and already the person doesn't have enough hemoglobin in their red blood cell. It then forces that red blood cell to collapse into that sickle shape. Now, white blood cells, like the macrophages, decide when they're patrolling the blood, they'll actually find that this is a damaged red blood cell, so they'll come and they will digest it. So in reality, anybody with sickle cell anemia is actually immune to malaria. They can't get malaria. And the interesting thing is there is a high prevalence of sickle cell anemia in Africa, and as a result, for example, in Africa, malaria is quite persistent in that region because these people are not going to get malaria. They are going to survive if they've got sickle cell anemia. And so malaria is still around because not everybody has developed that immunity to it, of course. So that was just a little bit of extra information. It's not something that you necessarily need to memorize. If you'd like to read up more about sickle cell anemia and malaria, I will provide you with some more readings, but it's not something necessarily that you have to focus on. It was just something that I thought you might want to look at as an interesting piece of information. Now, we'll just revisit these. Can you explain the different types of treatments for malaria? And in that, we're talking about the flowchart that we just looked at. Can you explain the preventative methods, that should say the preventative, I'll fix that, methods that can be used in regions with a high malaria incidence? And so, of course, we're just looking at the basic things like the list of, clothing, nets, removing stagnant water and things like that. So hopefully you understood that. Please don't forget to leave your feedback on Verso. There is a question on Verso about anti-malarial therapy. Leave your feedback on that. And as I always say, if you're struggling with anything in this lesson, please contact me. There's not a lot that I expect you to memorize there. It's just that generally that flowchart and the idea that you can prevent malaria. So if you have any questions, request help through Google Classroom or ask for a tutorial, and I'll be happy to accommodate that. And other than that, I'll see you in our week 13 material as we're now done with malaria and mosquitoes. All right. See you next time.